Good afternoon, and welcome to today's symposium sponsored by GE Healthcare, Changing the Beat in Cardiac Care with Advanced CT Technologies. I'm Jay Anders. I lead the CT business, the computed tomography business for GE Healthcare, and it's my pleasure to introduce Dr. Ricardo Cury today. Dr. Cury is the chairman of radiology at Baptist Health of South Florida and the director of cardiac imaging at Miami Cardiac and Vascular Institute. We installed the very first Revolution CT in the world at Baptist in 2014, and since that time, there have been several innovations, new technologies that we've continued to augment that platform with. And with Dr. Cury and his team's partnership, we've continued to push the boundaries of cardiac care. And Dr. Cury is going to share some of that experience with you today and how it has evolved over time. So with that, Dr. Cury, welcome. Thank you.
Thank you very much. Thank you. It's a pleasure being here. Thanks, GE, for the invitation to share our experience. As you said, it has been a good partnership since the installation of the first Revolution CT, and I'll be able to show, some of the evolution over time. So with that, these are my disclosures. And what are the challenges with CTA today? So in general, calcified plaques, obese patients, stents, motion artifacts, radiation dose, and being ready for new applications. I think that's a good summary of the main challenges that we have on a daily basis. And from a technology standpoint, there are different paths that a technology vendor can support with improvements in the spatial resolution, image quality, spatial resolution particularly for calcified plaques and stents, image quality for, in general, temporal resolution and software-based motion correction for motion artifacts, improvements with iterative reconstruction and deep learning, and new applications being ready with CT perfusion and CT FFR. So beginning with implementation in clinical practice, we have a large program at Baptist Health. We support 6 hospitals and 2 standalone ERs in South Florida. We have a large emergency department in our main flagship hospital with 100 beds. We have the 3 Revolution CT scanners supporting that in 3 different hospitals. We have other 64 slice CT scanners and high-definition CT scanners. And we have an operations of 7 days a week from 8 a.m. to 11 p.m. providing services on a timely fashion. So with that, we do approximately 6,000 coronary CT angios per year. So a good experience in cardiac imaging. The goal, the ultimate goal is really obtain good image quality and provide a good answer for the clinical question that we are attaining. So this is one example of a 1-beat, 16 centimeter, full 1 heartbeat coverage with high definition and motion free. In this case, we use 80 kVp, and radiation dose was 0.9 millisieverts to rule out coronary artery disease. So that we do on a regular basis. Our target is be below 1 millisievert, but in general 1 to 2 millisieverts radiation dose, and those are just other examples demonstrating low radiation dose CT angio on a regular basis. Then, and this is with the first generation of the Revolution CT scanner, can we overcome some of the clinical challenges? So this is a patient that had a heart rate of 79 beats per minute and had a bypass graft. So we had 2 slabs, so 16 centimeters covering the entire chest. But here we can see, if I go back, we can see a patient with bypass graft surgery. A patient had also anomalous, so in my arrow here, there was anomalous RCA. There was a metal device, so a left atrial appendage occluder device, but despite that, and even with a relatively high heart rate, we had a great image quality, and we were able to detect and diagnose all patent bypass grafts. Another case, a patient with, again, one beat, high definition, motion free, a patient with a heart rate varying between 52 and 90. You can see here the EKG strip. We acquired the images in the systolic phase, and we acquire motion-free images of the coronary arteries, even with irregular heart rate. So that was with the first generation of Revolution CT. Then applying deep learning, iterative reconstruction, that has been a big improvement to the image quality to decrease the image noise. So this is using the iterative reconstruction, ACER, and the image on the right, the deep learning iterative reconstruction, and you can see the significant improvement in the image noise. You can see several pixels in this image, and it's still preserving image quality. And this is instantaneously with the deep learning iterative reconstruction, and really producing a true natural looking image texture. So it's not that plastic image. It's definitely a more natural looking image texture, which saves those and improve workflow efficiency for our diagnosis. Other examples comparing the old version of iterative reconstruction on the left, and you can see more crisp and better detail delineation of the vessel, left main LAD, circ, with the deep learning image reconstruction. And with the combination of deep learning and a snapshot freeze, which is the motion correction, you can not only do 1D, but 2D. You can depict here a proximal LAD lesion, and you can do that with the, not only with the deep learning and the snapshot freeze, the proximal LAD severe stenosis, and you can see the improvement in motion by utilizing the software-based correction. So really, you have a good hardware, but also a lot of advances in software and iterative and deep learning iterative reconstruction to improve image quality and minimize motion. And all of those tools, they are very helpful in clinical practice. Another example, if you look at the EKG, you see the heart rate varying from 36 to 256. In the past, we wouldn't scan patients with irregular heart rate or with atrial fibrillation. Now, the CT scanner will not only acquire one beat, but if it seems it gets an ectopic beat, it will extend the acquisition to acquire a second beat, so that you have more data to reconstruct, and even having this 256 beat and the ectopic beat, we were able with a smart arrhythmia management and EKG editing to have a completely diagnostic coronary CTA in a patient that had prior aortic valve replacement. Another example, also, many of those cases, because of the high tube potential with the high MA, we use 80 kVp, and then we increase the MA for the tube. So this is an example of low kV imaging, but high MA, so 80 kVp and over 1,000 MA. This was a patient that we had also to acquire global left ventricular function and ejection fraction. So we had a radiation dose of 5 millisieverts, but we can see, there was just a non-calcified plaque in the mid-LAD, but otherwise, coronaries were not demonstrating significant stenosis, and still be able to acquire the left ventricular function with one heartbeat, so less than a second acquisition. Another case of software-based motion correction. So a patient with heart rate between 72 and 73, extensive calcified plaques throughout the right coronary artery. And you can see applying the motion-based correction software, how you can improve the delineation of the vessel and the accuracy. And with the new tube, we have been pushing the limits of the CT scanner. In general, we had a threshold for BMI of 50 BMI. We wouldn't scan patients with greater than 50 BMI. So this is an interesting patient. A patient had a BMI of 70. And you can see the scalp, you can see the subcutaneous soft tissue, so a lot of subcutaneous soft tissue fat. And we proceeded with this patient. We discussed with the cardiologist, and that was important, that the patient would be hard to do an invasive cath. And it was mainly to rule out coronary artery disease. So we proceeded, and these are like the axial images. And you can see, just stopping here, you can see the subcutaneous soft tissue fat. So really very large patient, but you can see the image quality. Here you begin to see the left main and the LAD coming through, but that's the takeoff of the left main and the RCA. But despite that very large BMI, completely diagnostic case, you can see the circ. This will be a dominant circ, the LAD and the RCA. So a dominant left circumflex artery and completely diagnostic case, even with that very high body mass index. And still, the radiation dose, we maximized the KV and the AMA, and the radiation dose was under 5 millisieverts for this case. So really a patient that we wouldn't be able to do beforehand. Another interesting case, also with a patient with AFib. We have now, like with the Revolution done, patients with AFib. Our initial cohort, we had over greater than 95% of patients with diagnostic image quality. This is one example with rapid ventricular response. And despite the high heart rate, was a triple rule-out case. So we extended the bolus. And we have a tube bead acquisition, so you can see, and the patient also had a bypass graft, so you can see the first venous graft crossing over the aorta. You can see good contrast opacification in the pulmonary artery. And this patient had this very large pulmonary emboli, so saddle PE. And you can see also the image quality for the coronary arteries, very good. There was RV distension and enlargement. RV-OV ratio was high. So this patient, we activate the PERT team, the pulmonary embolism rapid response team. But also, despite AFib and rapid ventricular response, really good image quality with a triple rule-out. Moving towards the new Gantry. Actually, we are installing our new Gantry rotation, 0.23 seconds temporal resolution as we speak. But we were able to collect images from another site in Europe that are already up and running. And now we'll have even better temporal resolution. So these are some images of with the new advanced Gantry rotation. So a patient with 139 beats per minute, so extremely high heart rate. And we can see completely, you can see the EKG here, so regular but high heart rate, motion-free images of the coronary arteries, and in this case, it was able to exclude a significant coronary artery disease. We can see calcified plaques in the proximal and mid LAD, and in the distal proximal RCA, but non-obstructive disease and good image quality. Also, other images from the new scanner with a Gantry rotation, a patient that had predominant calcified plaque in the proximal LAD with greater than 50% stenosis. We can see the cross-section. The green is the lumen, and the yellow is the calcified plaque. There was also some non-calcified plaque with the pink images, but we can see the narrowing in the cross-sectional image of patient with greater than 50% stenosis. Other cases from the scanner with a high temporal resolution. This was a heart rate of 69 and a dose of 0.6 millisieverts, so really low dose. And all those images were acquired in Brussels, in Belgium, and we see widely patent stent with no evidence of in-stent restenosis in the mid-LAD. Patient with high BMI, so BMI of 39, applying the deep learning. So all of these technologies, they are incremental with the fast Gantry rotation, deep learning, snapshot freeze, they all are additive with the goal of having robust image quality day in and day out. Another patient with irregular heart rate, so ranging from 61 to 161 beats per minute, and using auto-gating arrhythmia software, and we can see great images from all the three coronary vessels with minimal disease, minimal coronary artery disease in this case. And also patient with bypass graft. So a patient with Lima to here to the ramus intermedius branch, and Rima to the RCA, so we can see widely patent bypass grafts with patent distal anastomosis and runoffs. So shifting gears, so that allows us also to be using other tools, looking for perfusion, CT perfusion, both addressed in the ER, but also during stress and using regadenoson. But this is one patient that came in the ER, and we can see with the raw data a hypo-dense lesion in the infralateral wall, and with the color software better delineating that perfusion defect. This is a patient that had a prior infarct in the circ distribution, and the patient had a stented left circumflex artery. But that is also going into perfusion and looking at ischemia. So the value in cardiac imaging, so just shifting from the technology more like the experience and where we are heading, is really moving from the clinical accuracy. So a lot of focus in the past from quality of images, accuracy of reads, and refer comprehension, but really moving in establishing clinical pathways, very important, so that we are performing the right image test for the right patient at the right time, both in the stable setting, but also in the acute chest pain setting, and then coordination of care. So how we communicate the results of our report that can impact coordination of care. And a lot is the why CAD-RADS was really created by multiple societies. And the goal is really providing like a center of excellence in cardiac imaging. And we believe there are 5 components to provide that. One is patient selection, and patient selection was exactly what I said regarding dedicated clinical pathways with a chest pain protocol, with levels of care, and referrer and training comprehension. So that's the first step. The second step is the patient preparation with medication management, technologist education, and CT scan protocols. Then it goes into the subspecialty expertise, so having really the seamless on-site and cloud subspecialty expertise to expand coverage, utilizing advanced technology, so routing rules, 3D reformatting, and training. And then the coordination of care with its structural reporting and CAD-RADS, and ideally tracking outcomes so that we are looking at, how is the impact of the program in length of stay, in inpatient admission rates, cost of episode, and MACE events. So we were able to do that at Baptist Health, particularly with the acute chest pain program in the ER, and we follow inpatient admission rate after implementing not only the CTA program, but a clinical pathway that would really establish the right patient population, the low to intermediate risk patients that are in the chest pain center unit. We can see a significant reduction in inpatient admission rate, significant reduction in length of stay, average hours to discharge the patient, and the total cost of care. More importantly, the MACE events decreased from 1% to 2%. That was our MACE events to 0.2%. So really impactful where we can impact clinical outcomes with a comprehensive program, being, different papers describing the MACE events and the national average between 1 and up to 5%. Patients coming back in 30 days with an MI. So with that, we plan to expand, and we partner with Radiology Partners, who is the largest radiology group in the U.S. They are present in all 50 states with close to 3,000 physicians, doing 50 million cases per year, and basically taking care of approximately 10% of the U.S. population with outpatient imaging centers and providing care to large healthcare systems. So really providing that cardiac imaging center of excellence with dedicated experts, expanding after hours, having the 3D lab for post-processing, and having an advanced IT infrastructure to connect the technology stack. Regarding the 3D lab, it has been quite effective, both locally and regionally, but to stream the workflow, to centralize the expertise from a QA standpoint, reduce exam variability, increase productivity, and really grow services. And we see the 3D lab really being the foundation for expanding into 3D printing and VR, but also more recently really validating some new AI tools so that we have on-site technologists that can validate AI tools and implement in a more than a local level. Again, this follows like clinical pathways with 5 levels of care for the acute chest pain and training the sites. And these are some examples where providing services to sites in Texas, using the technology platform, moving the cases to the 3D lab, and then to export reads to provide read on a timely fashion. And also a similar example of providing services to other parts of Florida. And we believe that that's a win-win situation. So with that, also touching in CAD-RADS and coordination of care. Back in 2016, with SCCT, the American College of Cardiology, and the American College of Radiology, and ASCI, published the first CAD-RADS, which was based only in stenosis, going from 0 to 5. And with the new CAD-RADS classification, really moving into plaque and ischemia. So what is new with CAD-RADS 2.0? The stenosis grading, there is no change. Also, the committee discussed that so that we have backward compatibility. There is introduction of plaque burden grading from P1 to P4, denoting increased plaque burden from mild, moderate, severe, and extensive. And the modifiers, which we'd had 4 before, non-diagnostic, stent, graft, and vulnerability, we added 2 new modifiers. One modifier, we replaced the modifier V for vulnerability for HRP, and we added 2 new modifiers, HRP for high-risk plaque, and the 2 new modifiers for ischemia to adopt the sites that are doing FFR CT and CT perfusion, and modifier E for exceptions, which are related to non-atherosclerotic compressions of the coronary arteries, such as anomalous coronary artery and other extrinsic compressions. So modifier I for ischemia, really I positive if you have an abnormal CT-FFR less than 0.75 or an inducible perfusion defect by CTP, I negative if you have a normal FFR CT greater than 0.8, or either a fixed defect or normal perfusion, and an I borderline plus minus sign for sites, for cases that are borderline, for example, if the CT-FFR might be between 0.75 and 0.8, and not a drop-off, a significant drop-off in a short segment. So this will be discussed more, but this has just been released, and the great thing is that incorporates now CT-FFR and different grading for ischemia, and really CAD-RADS 3 and 4 are the ones that will benefit from either CT-FFR or CT perfusion, and that's the CT perfusion schematic where you have inducible perfusion defect being a modifier I for ischemia, fixed defect or normal perfusion, that will be no evidence of ischemia, and a patient with reversible perfusion defect and a small infarct, this will be also I positive, so positive for ischemia. And exceptions, which is the modifier E for exceptions, that will apply for example, coronary dissection, anomalous origin of the coronary artery aneurysm, vasculitis, fistula, extrinsic compression of the coronary artery, AV malformation, or other causes. Before, we wouldn't be able to grade that, but now with modifier E, we are able to include that. So it's really creating those centers of excellence, creating win-win situation for hospitals, and really expanding services and supporting local practices. With that, I think technology, we talk a lot about technology, but technology is one piece. It's really important to focus in processes regarding workflow efficiency, and really it all starts with people so that we can extract the highest value possible. With that, thank you, and we'll kick off some QA.